The rationale behind this study was that HER2-positive breast cancer, as defined today by immunohistochemistry and or in situ hybridization, is clinically and biologically heterogeneous. We had shown in the past that within HER2-positive disease we could identify 4 different intrinsic subtypes, so 4 different molecular groups defined by gene expression. And among them, one of them, the HER2-Enriched, previous data suggested that this subtype has the highest activation of the HER2 pathway. So with this background in mind, we decided to run a clinical trial, a prospective clinical trial called PAMELA, where we treated 151 patients, all HER2 positive, as defined by the standard criteria using immunohistochemistry and or in situ hybridization. And then these patients were treated for 18 weeks with trastuzumab, lapatinib, and endocrine therapy if the tumor was hormone receptor positive, so no chemo whatsoever. The patients after 18 weeks underwent surgery, and this is basically the design of the trial. Both pre or postmenopausal patients were eligible, and patients had to have stage 1 to 3A tumors with tumors in the breast with more than 1 centimeter in diameter. The overall PCR rate, which is the pathological complete response, was 30%. What was most interesting is that among the HER2-enriched subtype, this PCR went up to 40.6%, whereas in the non-HER2-enriched group, the PCR was 10%. So what we showed in a prospective way is that within HER2-positive disease, if you fall into the HER2-enriched subtype as defined by gene expression, you have a high likelihood of achieving a pathological complete response, which is disappearance of any invasive tumor cell. And this actually leads to future studies that might evaluate this group of patients as a potential target of de-escalating anti-HER2 treatment, in this case de-escalating chemotherapy.